Autosomal dominant polycystic kidney disease is a common genetic disorder occurring in approximately 1 in 1,000 live births. It is primarily caused by inherited mutations in the PKD1 or PKD2 genes. The PKD1 gene is located on chromosome 16 and accounts for 74 to 96% of cases. PKD2 is found on chromosome 4 and typically results in a less severe clinical phenotype. Polycystin proteins regulate calcium influx and cell-to-cell adhesion. Mutations lead to epithelial hyperplasia and fluid secretion into cysts that eventually isolate from the nephron. Massive cystic growth leads to progressive renal impairment and end-stage renal disease. Approximately 50% of patients reach ESRD by age 60 years. Patients often present with hypertension by the 4th decade of life. Clinical signs include bilateral flank masses and hematuria resulting from cyst rupture. Extrarenal manifestations include polycystic liver disease in over 80% of patients. Cerebral aneurysms occur in 8 to 12%, representing the most serious complication. Diagnostic ultrasound criteria for patients aged 15 to 29 years requires 2 or more renal cysts. This can be unilateral or bilateral in the presence of a positive family history. For patients aged 30 to 59 years, diagnosis requires 2 or more cysts in each kidney. This criteria yields 100% sensitivity and specificity for this age group. In patients aged 60 years or older, at least 4 cysts in each kidney are required for diagnosis. Stricter criteria are necessary as simple renal cysts become more common with advancing age. T2-weighted MRI can detect small cysts between 2 to 3 millimeters in diameter. Genetic testing using next-generation sequencing is reserved for atypical or ambiguous cases. Blood pressure control is essential, with a target of less than 130 to 80 millimeters of mercury. ACE inhibitors are the preferred first-line therapy to slow disease progression. Patients should maintain high fluid intake of 3 or more liters per day unless significant renal failure is present. Dietary sodium restriction is also recommended to manage progression. Vasopressin V2 receptor antagonists may be indicated for patients at high risk of rapid progression. These specialists' only medications carry a risk of hypernatremia. MR angiography is the primary tool for cerebral aneurysm screening in high-risk patients. Screening is indicated for those with a family history of hemorrhage or those requiring anticoagulation. Effective management focuses on aggressive blood pressure control and monitoring for extrarenal complications. Early identification of high-risk genotypes ensures timely intervention and preservation of renal function.